you very much, Dr. Chandra. This was a great presentation. Let me pass on the podium to Dr. Mahapatra for...
Okay, Dr. Diwakar Jain. Now, I think I would request all the chairpersons to be there and around and to start the discussion sessions. So now the floor is open for discussion. Now, Dr. Sawhney, Dr. Wanda, Dr. Diwakar Jain to conduct this.
Thank you, Dr. Mahapatra. My question is to Dr. Manoria. Dr. Manoria, sir, we are seeing now a new phenotype of heart failure with improved ejection fraction or recovered ejection fraction. They're going back to around from 30 to 50 or 55% ejection fraction. The many times physicians and the patient ask this question: how long shall we continue this foundational 4 drug? As we know that we can stop diuretic except MRAs, but foundational drug should be continued with this patient. And we have a study from TED CHF showing that if you stop it, you go back with the low ejection fraction. So question is, how long shall we continue this? Number 1. And number 2, can we have in some stage in follow-up, can have a step down in the drug doses? Dr. Manoria, sir.
Yes, very nice question. Firstly, the concept of improved ejection fraction is a misconception. Heart failure usually never disappears. It continues to run a malignant progression. So your question whether we can step down treatment if the patient improves, the answer is no to vast majority of patients. Although there may be improvement in symptoms, but apoptosis continues unabated, and suddenly you can land up hospitalization for heart failure, or in the early stages when symptoms are less, you can have a sudden cardiac death. So the aim of therapy in heart failure is escalation to the target dose unless side effects preclude their use. However, there are some exceptions, as you asked. Patients of peripartum cardiomyopathy or patients of myocarditis, they may recover to a great extent. And if you think of de-escalating therapy, ejection fraction should never be a criteria for de-escalation, because you can have subclinical dysfunction, left ventricular systolic, even in the presence of a normal. So if at all you want to de-escalate, you must measure GLS also. If GLS and ejection fraction both are normal in a subset like a peripartum cardiomyopathy where the recovery chances are great, or in a myocarditis, you may think of, but that has also been done very good. But in vast majority of cases, it is escalation and no de-escalation, because the vast majority of cases of heart failure are due to a progressive disease and they do not regress.
So they as you say, they are HFrEF in remission. I agree with you.
Yeah.
Question is that how long shall we continue?
It is an indefinite therapy for vast majority of patients.
Yeah.
Indefinite and indefinite.
Well, can I just chip in, JP here? Yeah, there is a study published in Lancet, which was Red HF or something. I don't remember the name.
Red HF.
That's what
it is. So this distinctly shows that if you withdraw drugs, a lot of these people will come back with heart failure. And then when you second time reinstitute these drugs, especially the beta blockers and the afterload reducing drugs, you will not get the same amount of benefit. So what Dr. JP Sawhney and Dr. Manoria both are, I think, emphasizing is that this phenomenon of improved ejection fraction was never there prior to beta blockers and the RAS blockers. So now that we have seen this kind of an improvement in, beta blockers cause more improvement in ejection fraction than ARNIs. The maximum ejection fraction, in fact, is improved with beta blockers. So once you use a combination, obviously these ejection fractions, as Dr. JP is telling us all, will improve. And then one has to be very, one should not have the temptation of course, diuretics will be withdrawn in most of these people, but you will continue with beta blockers. I just wanted to ask this very august audience. I know some of you are strong protagonists of ARNIs over RAS blocker or other RAS blockers.
Hello.
What is your current clinical practice in terms of Dr. Chopra can tell us, and Dr. JP has such a vast heart failure patient population, Dr. Manoria, and all these across the country, and I would say globe. What are your thoughts? Do you put your patients first on ACE inhibitor, ARB, and then switch over to ARNIs? And what is the current? Because there are schools of thought in both directions. So let's kind of hear to all of you experts, how do you handle these situations?
Thank you very much, Dr. Wander. I think it's a very, very important question. I like to respond, and I think first of all, the previous question which was raised by JP Sawhney and was discussed by Dr. PC Manoria, is no doubt that once we start ARNI or SGLT inhibitor, it has to be continued. We cannot reduce the dose. It has to be improved and sustained improvement. Sustenance is possible only if you continue the drug. It's just like tower or we do mitral clipping. We can't remove it when a patient improves. So we need to continue. That's the way. Second thing, I think Dr. Wander has asked regarding the role of ARNI as a first therapy or SGL2 as a first therapy. The answer is all the guidelines, whether this for HFpEF or for HFrEF. I think these four pillars are very, very important. We don't talk much of ACE inhibitors or ARB. ARB is there definitely in ARNI. I mean, there is no doubt about it. But there is a huge data coming up now on reversal of remodeling, which I mentioned there. A morphological remodeling, functional remodeling, and biochemical and biomarker remodeling, and even the cell reprogramming. This cell reprogramming will reverse. So I think things will change if you stop the drug. It has to be continued. And JP Sawhney was very firm in saying that how long should we continue? My answer is should continue and follow up this patient very meticulously. And I think it should be continued for a long term until and unless there is a condition like Dr. Manoria has mentioned on myocarditis, where we can reduce a little bit, but parameters should be there. A follow-up should be by echo and NT-proBNP. Echo is the real cornerstone.
Yeah, I think it's sorry, go ahead.
Yes. The sequence of initiation varies on the subset of patient. There's no fixed sequencing. If you have a patient of heart failure with hypertension, ARNI will come number one. If you have a patient of heart failure, BP is 90, SGLT2 will come first, beta blocker will first. If you have an advanced CKD, suppose there's 30 EGFR, then again we'll have SGLT2 and beta blocker first. So all depends on the subset of patient. Whether ARNI will proceed or whether SGLT2 or beta blocker will depend, individualize this patient and will depend on the subset of the patient. You cannot have a dogmatic statement that ARNI has to be initiated first or SGLT2 or beta blocker. All depends on the subset of the patient. In one subset, I think, beta blocker may score, as that may score.
The question Dr. Wander actually raised was very pertinent. That whether there are two types of thoughts right now, whether to start ACE inhibitors and ARBs and then switch over to ARNI or go direct to ARNI. I think to answer to that is that we don't have that head-to-head comparison study like this where we go direct to ARNI and we go from step 1 to step 2. But certainly with the data which we have, it is absolutely reasonable to go directly to ARNI also in those patients who are at least low ejection fraction, HFrEF patients, and those who have blood pressures which can actually tolerate this, and we can even start this in the hospital period. And many times we do that. So I think it is at this time, we are extrapolating all that information, but definitely, and we have small data on in-hospital patients receiving ARNI straight away. So that ARNI therapy can be initiated as a first line therapy in these patients. And definitely it is one of the components. We are not saying, Dr. Manoria, that you are replacing everything. We are saying that, it has to be part of that therapy if the blood pressure and rest of the things renal functions are permitting. So I think, and the last thing, Dr. Sawhney, which was mentioning about how long, I mean, the answer, I don't think we have that clear answer as to for how long, even if the EF improves. If the EF is not improving, we have to continue. Yeah. But sometimes we see patients' EF is 55% after 6 months or a 1 year course. So
I just like to mention, I just like to mention a comment here. Like Dr. Praveen Chandra has given a very important information, but there is a lot of data coming up. The EF should not be the only criteria. We have to think of LA strain, longitudinal strain, which is a very, very important variable, and the remodeling. When we talk of remodeling, it has to be all the 4 chambers. 4 chambers remodeling, data is emerging out. We don't have data at the moment, but a lot of data is emerging out. Even the anti-fibrotic component is by LA strain. So I think these are all new things which are coming up now, but ejection fraction per se is not only the parameter which we have to consider. once we start ARNI or SGLT inhibitors?
Yeah, I think it's important that to explain the patient when they ask how long to continue, it's, to me, I give them the example of like hypertension, diabetes, hyperlipidemia. The fact that you have controlled them doesn't mean that now you can stop the treatment. So I tell them it's no different than any of those entities. Control means the medications are doing the job. And in order to derive the benefit, you got to continue just like you will continue antihypertensive. Now, if the blood pressure is normal, that doesn't mean you stop it. So I think heart failure should be no different, that if the medications have improved the ejection fraction, with a rare exception like Takotsubo or myocarditis, those may be different conditions, but vast majority of heart failure patients, even if they improve to a normal level, I think some dose of treatment, you may have to cut down on some of the doses, but they got to continue for indefinite period of time. The question is, will they eventually 10 years, 5 years later go again into heart failure or not? I think that issue remains unresolved. Some people do worry about it, that it is a relentless condition. Yes, you can improve their cardiac function symptom, but maybe 5 years, 10 years later, it will show further decline in function. That part remains unclear.
Just one question, Dr. Jain. I think a lot of patients which we see here who are in heart failure, and as Praveen Chandra and Dr. A.B. Mehta just pointed out, when we give them a device therapy, like in the form of TAVI, or I know Praveen Chandra has done a lot of tricuspid valve, percutaneous valve replacement. So when we do device intervention and a patient is already on drug, does the drug requirement reduce? I have no answer. I'd like to have the comments of our chairpersons or any of our speakers.
I think the one thing which guidelines have come up, like you have given a device therapy when the ejection fraction was low, less than 35 or so, and suppose you are given an ICD or CI, and we found now ejection fraction is 60% and the battery life is over. So shall we replace the battery? That is the question which came up. I mean, the guidelines are in favor. I think if you are very certain that probably this patient ejection fraction is certain, we need not have to renew the battery in this patient. I'm not sure about, but I will ask my other colleague, Dr. Jain and Dr. Praveen, to answer this question.
You know, this is a complicated question. I tell you my take on that. Those patients who get ICD as a primary prevention based upon ejection fraction criteria or any other criteria. Now, 5 years later, the patient has not used the device and they're due for replacement of the battery. It's not a part of the guideline, but I think probably we should consider, does the patient still qualify for, if this patient did not have a device, would you put the device now? If not, why do we continue? Now, most in USA, the issue is of liability. Nobody wants to take their liability. It's much easier to replace it. And after all, money is involved in that too. So nobody has incentive to think. But in my opinion, one should consider, at least in a subset of patients where these ICDs are put in as a primary prevention based upon ejection fraction criteria, and ejection fraction has improved, and patient has never had device activation. Then at the time of replacement, you should consider, do we really need to do it? Then the question would come in, if you are not replacing the battery, do you extract it or just leave it there? To me, it looks like a common sense, just leave it there. If ever needed, you could replace the battery, but again, there are no set guidelines. This is a work in progress kind of thing that we need to raise the awareness and maybe come up with some agreement for that.
I just one question to Dr. Wander, Dr. Sawhney, and Dr. Chandra together. If you do LVAD, in LVAD, when a patient is already on a complete therapy of SGLT2 and ARNI, the requirement of these drugs reduce or it does not reduce? How do we prognosticate the patient who are on a heart failure therapy versus patient on LVAD or RVAD or BiVAD? We like to have opinion, because people who are like Praveen Chandra or Dr. A.B. Mehta are doing these procedures and following these patients with the therapy. What's their experience?
Okay, so let me just answer this question in totality, that what happens after these procedures in low ejection fraction patients. In cardiomyopathy or ischemic cardiomyopathy, actually, if we are talking about, so those patients who are having ischemic cardiomyopathy, systematically, we assess whether these patients are having hibernating myocardium or they are totally infarcted myocardiums. So those patients who have hibernating myocardiums on a cardiac PET CT scan or MRI scan, in these patients, definitely these patients improve after doing the intervention. And as you saw from the data from the Impella study and also from many studies where revascularization was done completely, full revascularization, the ejection fraction improves. And definitely these patients, the dose of these therapies can be reduced in these patients once the AF improves after revascularization. The second is those patients who have valve implantations like TAVR, or patients who are having mitral clip implantation, or those patients who have TMVR. In these patients, again, the dose of these drugs can be reduced quite dramatically, and diuretics are definitely off very initially. And once the EF improves in these patients who have undergone valve implantation procedures, I think it is reasonable to de-escalate therapy and if the ejection fraction is improved. The last question is about the CRT devices. Actually, for ICD, it is simple. If you can check, if there is no shock, there is no VT, and these patients have improved ejection fraction, there's no need to replace the ICD. But in CRT patients, the question is a little difficult, because if the patient has improved after a CRT implantation, his doses are also reduced, and what to do with the failed batteries going. So in these patients, I think it is still reasonable to replace the batteries, because we don't know, we don't have the data that whether, if you don't replace the battery, whether the EF will go down again or not. So that's where the situation is right now.
Yeah, couldn't agree with you, Praveen, more than exactly what I was going to say, that ICD and CRT should be looked at in a different totally manner. And ICDs, of course, all these issues once EF comes back to normal, I mean, no shocks, but CRT certainly at least I would like to replace it, because a lot of it would have been, CRT is an excellent form of therapy, we all know. We talk of newer therapies today, but CRT produces one of the most dramatic improvements in these patients. So one would certainly like to replace it. Just one short comment on sequential therapy. There was a trial which showed that beta blockers, once they are delayed to these people for a long time, I know we spoke about sequential, it can be kind of detrimental for some of these people. So once we have heart failure controlled, beta blockers should be instituted early. And this was a comparison between beta blocker first or ACE inhibitor first, and beta blockers scored over that. Now I was reading in JAC, there's a lot of people have collected together and given opinion on some of these studies. They show that these SGLT2 inhibitors can even be started pre-discharge, or so to say, rapidly after discharge. Although we don't have data in terms of trials, but certainly there are smaller studies. And so since there is so much promise with these agents, we have some sort of a consensus kind of an opinion which says they can be started pre-discharge. So early use of these drugs can be done.
Yes, Emprise studies published AHA 500 patients shown pre-discharge. EMPA has been given in HepPEF or HepREF, diabetic and non-diabetic, and they have shown good results. So we can start safely. Single dose, no titration, no hemodynamic difficulty, whether improvement in renal function, prevention of hyperkalemia. So there's so many benefits. So I think safest drug to be given in heart failure patient as early as probably SGLT2 inhibitors.
Okay, we have a few questions from the audience for Dr. Manoria. I think maybe the three questions for Dr. Manoria. Do SGLT2 inhibitors have any antiarrhythmic effect? And the second question, I think you have let me just read all the questions so you can answer them together. Can we de-escalate drugs? I think that has been discussed in great detail. And also, another question for Dr. Manoria, you did not clarify SGLT2 benefits in all, whether it is all CKD or in some CKD patients.
SGLT2 inhibitors have definite antiarrhythmic action. I've already shown you the data of the DAPA-HF trial, the decreased ventricular arrhythmia. Regarding CKD benefit, it is more benefit for proteinuric CKD. But now for the interstitial disease of the kidney, we have a newer agent, finerenone, which targets inflammation and fibrosis. SGLT2 inhibitors and RAS blockers target intraglomerular hemodynamics. And in the Fidelio and the Figario trial, 5% of patients were all on these three drugs. I do not have access to this data, which seems very interesting. So the approach for CKD benefit, if you want to target intraglomerular hemodynamics, RAS first and then SGLT2. And if you want to target interstitial disease, finerenone will have an edge, although there could be combination of both.
Any other?
Excellent.
Any
I have
other?
question to Dr. Manoria. Can I ask?
Yes.
Hello.
Short question, Dr. Parasa, please. Ask.
What is the cut point of EGFR for using SGLT2 inhibitor? And what are the subset of the patient where the SGLT2 should not be used? Please.
The cutoff point for use of SGLT2 inhibitors varies. What is your aim of use of SGLT2 inhibitors? For glycemic control, the cutoff point is 45. For heart failure, it is 30. For CKD, previously it was 30, but EMPA CKD is running up to 20. So the cutoff point depends on the subset. If you are using below these, it becomes an off-label indications, which sometimes we have to use. The contraindications for use of SGLT2 inhibitors are type 1 diabetes. Usually we avoid very late stages of type 2 diabetes who are insulinopenic, because if you give SGLT2 inhibitors to a basal bolus regimen, ketoacidosis may be precipitated. If the BMI is very less than 18 in Indians, it is better to avoid. Advanced CKD means EGFR less than 20, 15 is not recommended. So these, and the preoperative states also it is withdrawn. So these are some of the contraindications where we will not like. Otherwise, for diabetic patients, for heart failure patients, CKD besides these, they have to give in to all these subset of patients.
Dr.
Okay,
Jain,
thank you, Dr.
other
Manoria.
question, Dr. Jain, from the chat box, 1 or 2 quick questions because we are running short of by 15 minutes.
Yeah, there's one more question for Dr. Nanda. Should diastolic stress test be done as a routine in borderline heart failure with preserved ejection fraction? Also, lung USG reduction in LA, LV strain, pulmonary artery systolic pressure, etc. This is for Dr. Nanda.
Yeah, I think so. I think it's a very good question. I think if the patient does not fit the criteria, which I already given, then I think in those patients, very important to do the diastolic stress test, and can be done either on treadmill exercise or semi-recumbent or recumbent position, making sure that you don't exercise so much that E and A wave skews, and then you have problem in getting the ratios. I think out of these, most important thing is to look at the increase in the pulmonary artery pressure.
Any other question, Dr. Jain, from the chat box?
No, that's all from the chat box.
Last comment, I want that some of the contraindication of SGLT2 inhibitor, which we know also is like pregnancy, lactation, insulopenic condition, septicemia, acute myocardial infarction with heart failure. The trial is still going on, impact heart failure trial with EMPA at the moment. So there are some more area where we should not use, and the repeated genital infection, of course, that is very important. We should not use this drug.
Okay, thank you very much to all the eminent speakers like Dr. Manoria, Dr. Naveen Nanda, Dr. H.K. Chopra, Dr. A.B. Mehta, and Dr. Praveen Chandra. Thank you to all the chairperson. It was a very wonderful sessions and the discussions was super.